I'm Dr. Fakir Obari, and this is pulmonary tuberculosis in adults. Tuberculosis, or TB, is caused by Mycobacterium tuberculosis complex. Approximately 2 billion people are estimated to be infected with Mycobacterium tuberculosis, including 13 million people in the United States. It is transmitted almost exclusively by cough aerosols, and pathologically, it is characterized by necrotizing granulomatous inflammation, usually in the lungs, causing pulmonary tuberculosis, although extrapulmonary sites can be involved as well. Untreated tuberculosis has a 10-year mortality of 70% in smear-positive people and 20% in smear-negative people, and these rates are much higher in patients with HIV. And of course, with treatment, mortality is lower, but still around 2.5% of people without HIV, as well as 14% of people with HIV can die from tuberculosis even with treatment. Increasing age, more extensive disease, and HIV co-infections are associated with increased mortality. Mycobacterium tuberculosis complex consists of multiple species, many of which can infect both humans as well as animals. Mycobacterium tuberculosis infects humans and is the most common cause of tuberculosis. Mycobacterium tuberculosis is often referred to as acid-fast bacilli, and that is because of the staining that's done in order to identify these organisms under the microscope. So the acid-fast stain is what is used, and that is because of the differences in the cell wall of mycobacteria. So in general, mycobacterial cell wall consists of a large layer of mycotic acid, as opposed to peptidoglycan. So because the peptidoglycan is covered by this large layer of mycotic acid, gram staining is not really achievable. So mycobacterial cannot be identified as either gram positive or gram negative. So we do use acid-fast staining. In addition, mycobacteria grow very slowly. So you can see visible growth 3 to 8 weeks on solid media, and in liquid media it takes 10 to 20 days. Whereas for normal bacteria, it typically takes a day or two to see visible growth. Let's take a look at some definitions. So latent tuberculosis infection is referred to someone who has the Mycobacterium tuberculosis organism, but they do not have any symptoms. So this is asymptomatic and also non-transmissible. So someone who has latent TB cannot transmit the infection. Active pulmonary tuberculosis, which is transmissible, is actually in the presence of symptoms in the pulmonary area. And these symptoms include fever, night sweats, weight loss, cough, and hemoptysis. And hemoptysis is coughing blood. Drug-susceptible tuberculosis refers to organisms that are susceptible to isoniazid or rifampin. And multi-drug resistant tuberculosis is referred to organisms that are resistant to at least isoniazid and rifampin. So it has to be resistant to both of them, isoniazid and rifampin. And extensively drug-resistant tuberculosis is referred to basically organisms that are not only resistant to isoniazid and rifampin, but also resistant to any fluoroquinolone and resistant to at least one second-line injectable drug. So either amikacin, streptomycin, kanamycin, and capreomycin. Although multi-drug resistant and extensively drug-resistant TB is a global issue, in the United States they are extremely rare. So the majority of cases in the United States are actually drug-susceptible tuberculosis. So in this topic, we will only focus on drug-susceptible tuberculosis. Let's take a look at some reliable resources for tuberculosis. IDSA has several guidelines. In 2016, they released guidelines for treatment of drug-susceptible tuberculosis that we will focus on during this topic. They also have guidelines for diagnosis of tuberculosis in adults and children. They also have separate guidelines published in 2019 for drug-resistant tuberculosis, which we will not cover in this topic. And most recently, in early January of 2025, they released updates on the treatment of drug-susceptible and drug-resistant tuberculosis. So these are in addition to the previous guidelines, so they're not a replacement. So there is recommendation that will add to the previous 2016 guidelines from here. And then there are other guidelines available from the CDC and WHO. And of note, for latent tuberculosis, we will use CDC guidelines. And for HIV individuals, we also have DHHS guidelines for opportunistic infections. While TB is not an opportunistic infection specifically, it is covered in these guidelines, so we will touch on those recommendations. The first learning objective is describe the pharmacokinetic and pharmacodynamic properties of antimycobacterial agents. Here's a general overview of mechanism of action of agents used for tuberculosis in general. There are 4 agents that are used as first line for drug-susceptible tuberculosis, and everything else is reserved for drug-resistant, either multi-drug resistant or extensively drug-resistant tuberculosis. So the first drug that we use is the class of rifamycin. So rifamycins in general inhibit RNA synthesis by targeting RNA polymerase. So they inhibit RNA polymerase. The second class is, or the second drug is isoniazid. So isoniazid inhibits mycolic acid synthesis. So as you remember, in the cell wall of mycobacteria, there is mycolic acid, which is a thick layer above peptidoglycan. And by inhibiting its synthesis, these drugs can actually kill mycobacteria. Ethionamide has similar mechanism of action as isoniazid, but it is not used for drug-susceptible tuberculosis. It is second-line agent reserved for drug-resistant tuberculosis. The third agent is ethambutol, which also inhibits cell wall synthesis, and the fourth agent is pyrazinamide, which also inhibits cell membrane synthesis. So the 4 agents are rifamycins, isoniazid, ethambutol, and pyrazinamide, which we refer to as RIPE, which I will discuss shortly. Now, everything else is actually reserved for drug-resistant tuberculosis, including fluoroquinolones. So with the exception of ciprofloxacin, which is not active, so levofloxacin, moxifloxacin are actually active against Mycobacterium. Streptomycin is an aminoglycoside, so both streptomycin and amikacin have activity against Mycobacterium, and they are reserved as injectable drugs for drug-resistant tuberculosis. Macrolides are active against some Mycobacterium, so we have seen azithromycin and clarithromycin used for MAC, for example, not typically used for tuberculosis. And then we have ethionamide, and we have vidaquilin, as well as oxazolidinones, which are basically the most common one would be linezolid, is what's reserved for drug-resistant TB. And more recently, we had pyritonamide approved by the FDA, which is a bicyclic nitrominidazole, and this is also reserved for drug-resistant TB. Let's take a look at rifamycin. So in general, we have 5 rifamycins. Rifamycin is also a drug, so the whole class is referred to as rifamycin, but just like tetracyclines, where there is a drug called tetracycline, there is a drug called rifamycin, which is primarily used for traveler's diarrhea, and we don't really use it that much, so I'm not going to talk about it. But the other 4 are more commonly used. So Rifampin, Rifabutin, and Rifapentine are used for TB. Rifaximin is also rifamycin, but it is not used for TB because it's an oral drug that's not absorbed. So in general, we use it for hepatic encephalopathy and for recurrent C. diff infection. It can also be used for traveler's diarrhea and some other indications off label, but not for TB. All rifamycins have the same mechanism of action. They bind to the beta subunit of bacterial DNA-dependent RNA polymerase, so they inhibit RNA synthesis. So if there is resistance to one, there is cross-resistance across all of them because they have the same mechanism. But no cross-resistance with other classes of antimycobacterial agents. One thing to keep in mind is that mycobacteria penetrate into phagocytic cells. So a property of agents that we use for tuberculosis is that the agents need to penetrate inside those cells in order to have activity. Isoniazid is a prodrug that's activated by an enzyme called CAT-G, and mutation in this CAT-G can lead to resistance. There can also be efflux pumps, and there has been some cross resistance between isoniazid and ethambutol. So if it's resistant to isoniazid, there's a good chance that it will be resistant to ethambutol. Pyrazinamide is also a prodrug that's activated by an enzyme, and mutations in this enzyme can lead to resistance, but no cross resistance has been observed with pyrazinamide. And ethambutol can also have resistance by mutations in one of these genes, and they obviously can have cross resistance with isoniazid. We described the pharmacokinetic and pharmacodynamic properties of antimycobacterial agents. Now let's differentiate between latent tuberculosis infection and active pulmonary tuberculosis infection. The infection begins by inhalation of bacteria through nose or mouth and then into the lungs. They typically go to the upper region of the lungs because oxygen content is higher at the top of the lungs. Although lower lobes can also get infected, but upper lobe infection is more common. Don't confuse this with upper respiratory infection. Upper lobe is still in the lung and is considered lower respiratory infection. Once the bacteria get into the alveolar space, they encounter the alveolar macrophages. The immune system starts to kill the mycobacteria. If the first line defense fails, the mycobacteria can penetrate the lung interstitial tissue and enter the lung parenchyma. In the alveolar space, the dendritic cells will present these mycobacteria to the lymph nodes for T cell priming. Then the lymphocytes, both B cell and T cell, will come and find the mycobacterial in the lung parenchyma and contain the infection. As a result, a structure called granuloma will form, and inside the granuloma, the mycobacteria can reside and start to replicate, or they can remain inactive, which leads to latent tuberculosis. Because the mycobacteria are contained in the granuloma, someone with latent TB is not infectious. Now, what can happen over time is that the granuloma grows and gets bigger. At some point, it will not be able to contain the mycobacteria anymore. At that point, the granuloma will actually rupture, and then the person becomes infectious because the person can cough and transmit the mycobacteria to other people. At this point, the person is considered to have active tuberculosis. The mycobacteria can also go to other parts of the body and cause extrapulmonary manifestations. Let's take a look at different spectrum of tuberculosis manifestations. So we can, at each stage, look at tuberculin skin test, interferon gamma release assay, culture, sputum smear, which is basically staining, acid-fast staining, and then if the person is infectious, has symptoms, and if the treatment is preferred. So someone with innate immune response is someone who has actually cleared the mycobacteria. So therefore the TSD and IgRA will not test positive, and obviously there will not be anything on culture or smear or sputum smear. This person will not be considered infectious and will not have symptoms. Now, if someone had already been exposed to mycobacteria and as a result of T cell priming had immune response, on a subsequent exposure to mycobacterium, the immune system can actually get activated and clear the virus. For someone like this who will not be considered infectious and will not have symptoms, nothing will be on cultures and the sputum smear will be negative. However, the TSC and IgRA will test positive because of this immune response. Now, this can transition into someone who actually has latent tuberculosis. So this is someone whose immune system could not handle the mycobacteria, and this person will have granuloma. Because the granuloma will contain the infection, this person will not have symptoms. So this is not symptomatic, and the person is not considered infectious. The TSD and interferon gamma release assay will test positive in this person, but the culture and smear will be negative. Now, this can transition over time to active TB, and in between latent tuberculosis and active TB, there is a phase called subclinical tuberculosis, which is very difficult to diagnose. And these are basically the patients that could sporadically be infectious as these granulomas start to release the mycobacteria. And they could have mild symptoms, or these patients could actually be asymptomatic. And these patients will have TSD or IgRA positive, and sometimes the culture can be positive, and unfortunately the sputum smear is usually negative, which makes it difficult to catch. And of course, when it comes to active tuberculosis, the patient is typically symptomatic, and the symptoms can be severe. The person is considered very infectious, and everything will be basically positive. So TSD, IgRA, and culture, and the smear is often positive. So a small portion of patients can have a negative smear, but most patients will have a positive. And treatment is recommended for someone with active TB, and if you can catch subclinical TB, the treatment is recommended. And for latent tuberculosis, is basically preventive therapy. So the person is not considered infectious, but we do give them treatment in order to prevent progression into subclinical and active TB, because these two not only have severe consequences for the person, but they can also lead to transmission of infection to other people. Here are the recommendations from 2017 IDSA-CDC guidelines for diagnosis of tuberculosis. In general, the interferon gamma release assay is preferred over the tuberculin skin test, especially in these four populations, including patients who have received the BCG vaccination. Most other countries have routine vaccination of BCG, and because this can lead to false positive skin test, it is recommended for these patients to have the IgRA used over TSD. Now, having said that, IgRA is typically more expensive and also may not always be readily available. So the TSD is an acceptable alternative if the patient does not have access to IgRA. Now, these two tests will test positive in both latent tuberculosis as well as active tuberculosis. So really what distinguishes active from latent is really the absence of symptoms. So if someone has tested positive but they do not have symptoms, and on a chest x-ray, if the chest x-ray is normal, that's really how you diagnose latent tuberculosis. Interferon gamma is released by sensitized T cells in response to highly specific Mycobacterium tuberculosis antigens. We have two commercially available assays: the QuantiFERON TB Gold Plus, which has essentially replaced the older QuantiFERON TB Gold in Tube, which was available in the US, and the second assay is the T-Spot TB test. Now, the results of these assays are either positive or negative. In case they turn out to be indeterminate, it is reasonable to repeat the assay. And of course, for tuberculin skin test, which is the cheapest way to test, there are a couple of limitations. One is that the patient has to come back in order to get the results read. So, you cannot get the results the same day. As well as anybody who had the BCG vaccine, they can have a false positive. Another issue with tuberculin skin test is that in some people who are infected with Mycobacterium tuberculosis, the ability to react to tuberculin may wane over time. So when given a skin test the years after infection, these people may have a false negative reaction. Now, one thing we have seen is that when you give the skin test, the tuberculin skin test, it can actually may stimulate the immune system, which is referred to as a boosting. So for people who get tested routinely, like healthcare workers, it is recommended to get a two-step skin test. And what that means is that you give the first test, and if the first test is negative, because it could be a false negative due to waning of the immune, the person's immune response, it is recommended to repeat that test within 1 to 3 weeks, because the first test will actually boost the immune response. And then the second test that's given 1 to 3 weeks later, if it tests positive, then you can actually catch more latent tuberculosis by avoiding a false negative. Now, if that second test is also negative, then you can actually rule out a latent tuberculosis. Now, when you diagnose latent tuberculosis infection, not everybody is likely to transition into an active TB. Some populations are at higher risk. So the higher risk of progressing from latent to active is typically children aged less than 5 years. HIV infection, people who take immunosuppressive therapy, so such as organ transplant patients, and patients who had abnormal chest x-ray consistent with prior TB. So if they've had active TB before, they're more likely to have TB again. As well as silicosis, which is basically a form of occupational lung disease caused by inhalation of crystalline silica dust. So these patients are at higher risk of progressing to active TB, so they are more likely to benefit from treatment of latent tuberculosis. Whereas other patients, they might be at intermediate risk of getting active TB, and really the evidence hasn't demonstrated a clear benefit if you treat latent TB. Now, for diagnosis of active TB, obviously, it depends on the presence of symptoms suggestive of tuberculosis, as well as a chest x-ray showing cavities or other signs of active TB. An important part of diagnosis of TB is the acid-fast bacilli or AFB smear microscopy. And in general, it is recommended to get 3 specimens every time there is a smear microscopy performed. In addition, it is recommended to get a mycobacterial culture, both liquid and solid media. There have pros and cons. It takes longer for solid media to show growth. However, you can get morphology on solid. So both liquid and solid are recommended. Nucleic acid amplification test is recommended, and it is routine in practice. One of the common assays used is the expert MTB RIF test, which can basically tell you the same day if the patient has Mycobacterium tuberculosis. It can also test for resistance against Rifampin. So that's why you see RIF here. Now, the traditional susceptibility testing from the mycobacterial culture may take up to 8 weeks for the results to come back. So because up to 8 weeks, we may not know if the regimen that we're using is susceptible or not. That molecular testing that gives you the Rifampin test the same day is really important for these patient populations. So including someone who has been treated for TB in the past, because the Mycobacterium tuberculosis could have developed resistance as a result, or if someone has contact with patient with multi-drug resistant TB or HIV infected patients. It's important to know very quickly if Rifampin is susceptible or not, because if it's not, then an alternative regimen needs to be used. We described the pharmacokinetic and pharmacodynamic properties of antimycobacterial agents, and we differentiated between latent tuberculosis and active pulmonary tuberculosis infection. Now, let's initiate a medication regimen in a patient with latent tuberculosis infection. Here are the recommendations from the 2020 CDC guidelines for treatment of latent tuberculosis infection, which really you can think of as prophylaxis since these patients don't have an active infection. Because the patients with HIV are at high risk of mortality from tuberculosis, the evidence for treatment of latent mycobacterial tuberculosis is really based on whether the patients have HIV or not. In general, there are three regimens that are considered preferred by the CDC. The first one is a once-weekly combination of isoniazid and rifapentine. And I should say that historically, the treatment of latent tuberculosis used to be 9 months of isoniazid monotherapy. So anything else is really in comparison to what used to be the standard of care, which was 9 months of daily isoniazid. So the preferred regimen, the first preferred regimen is the once weekly isoniazid plus rifapentine, and compared to 9 months of isoniazid daily, it is really associated with less hepatotoxicity. So significantly less hepatotoxicity and high efficacy. So because of high efficacy and less hepatotoxicity, this regimen is really considered first line. And because it's once weekly, it's really easier for adherence. Now, there are some downsides to this. So for example, even though it's once weekly, it has a high pill burden. So there are 10 pills that the patient has to take once a week. And it's relatively more expensive compared to the other options here. So sometimes the cost can be prohibitive. And another thing is that historically, this combination that's given to patients once a week, it was given as directly observed therapy, meaning that the patient actually had to go to their provider once a week, so the provider can actually observe the patient take this combination. And that was really to ensure that the patient is adherent. And that could also be costly. So if you have to make a weekly follow-up meeting with your provider, that's going to add to the cost. Now, in recent time, there was a study that showed that self-administered therapy, meaning that you do not need to go to your provider's office for them to observe, taking this regimen, was actually non-inferior to directly observed therapy in the United States. So now it's actually okay if the patient, takes this regimen based on self-administered therapy. So this recommendation is a strong recommendation for both HIV negative patients as well as HIV positive patients because of the good evidence in support of this regimen for both populations. Now, the second regimen that's also considered preferred is a once daily monotherapy with Rifampin. And this monotherapy would have to be for a total of 4 months. And compared to what used to be the standard of care, which was 9 months of isoniazid daily, this regimen is also less hepatotoxic, so significantly less hepatotoxicity. However, Rifampin is a strong inducer of CYP enzymes, so this regimen is considered with many drug-drug interactions. And because it's monotherapy, if you, for some reason, miss the patient having an active TB, or if the patient has subacute TB, they're more likely to develop resistance to Rifampin if this patient takes Rifampin monotherapy. But in general, for latent tuberculosis, Rifampin monotherapy is very efficacious. So it is a strong recommendation for HIV negative patients. Unfortunately, there's really no evidence to support this recommendation for HIV positive patients because it has not been studied. So there's it's not really recommended for HIV positive patients. Now, if someone cannot take Rifampin because of drug-drug interactions that are contraindicated, and if that patient also does not qualify to take isoniazid because of hepatotoxicity, it is recommended that Rifabutin, another rifamycin, can be substituted for Rifampin because Rifabutin has less drug-drug interactions compared to Rifampin. And the third agent that's considered preferred is the combination of isoniazid and Rifampin once daily for 3 months. And this is not a strong recommendation, it's a conditional recommendation. It is, compared to 9 months of isoniazid, this has less hepatotoxicity. It still has isoniazid, which is hepatotoxic. So, daily isoniazid can lead to hepatotoxicity. So it is definitely more hepatotoxic compared to rifampin monotherapy. And because it's for 3 months, discontinuation due to adverse effects do occur in patients. So for that reason, it's not really a strong recommendation. And of course, it has rifampin in it. So if the patient has subacute TB or active TB and didn't get diagnosed, this patient can develop rifampin resistance with this regimen. And then isoniazid daily monotherapy is considered alternative, primarily because of the long duration of therapy. So you need at least 6 months of therapy, and the standard of care used to be 9 months of therapy with this, which leads to very high risk of hepatotoxicity. And a combination of long duration and hepatotoxicity led to low completion rate. So patients just stopped taking it because of the low tolerance and long duration of therapy. So for that reason, these are considered alternative. Let's take a look at recommendations from DHHA's guidelines for opportunistic infections in patients living with HIV in regards to treatment of latent tuberculosis infection. The preferred regimens include isoniazid plus rifapentine, and because HIV infection is a risk factor for isoniazid-associated peripheral neuropathy, anytime you see isoniazid, there will be a recommendation for pyridoxine. So isoniazid plus rifapentine for 3 months or specifically for 12 weeks. And this is specifically for virally suppressed patients receiving either an efavirenz, raltegravir, or once daily dolutegravir based regimens. The second preferred regimen is isoniazid plus rifampin. This is a daily regimen for 3 months. And then we have alternative regimens for people who cannot take one of the preferred. And these are in order. So the first alternative is isoniazid, essentially monotherapy, and of course you will add pyridoxine. This is for 6 to 9 months, and this has high risk of hepatotoxicity. The second alternative for people who cannot take the previous regimens is rifampin daily, and this is monotherapy for 4 weeks. And again, this is a second alternative because of lack of clinical trials in people living with HIV. And specifically for these patients, rifabutin cannot be replacing rifampin. So if they cannot tolerate rifampin either, rifabutin monotherapy is not recommended. And lastly, what's been emerging in the literature is a very short 4 weeks treatment with isoniazid plus rifapentine daily. And this is emerging not necessarily in patients who had latent tuberculosis, but also patients who did not have latent tuberculosis but lived in a high prevalent regions at risk of tuberculosis. And this was able to prevent emergence of TB in these patients. Of note, the guidelines recommend this only for patients receiving an efavirenz-based regimen, which is not the first-line regimen. So, this has limited utility in the US, but the data are emerging to see if this can be effective in other patients. We described the pharmacokinetic and pharmacodynamic properties of antimycobacterial agents and differentiated between latent tuberculosis and active pulmonary tuberculosis infection. We also initiated a medication regimen in a patient with latent tuberculosis infection. Now, given an active pulmonary tuberculosis patient case, recommend ATS-CDC-IDSA guideline concordant first-line therapy. The goals of therapy include rapidly reducing the number of actively growing mycobacteria and eradicating populations of persisting bacilli in order to prevent relapse and to prevent acquisition of drug resistance during therapy. There are 2 things that are associated with increased risk of relapse. One is signs of more extensive disease, which is typically cavitation or more extensive disease on chest radiograph, as well as slow response to treatment. So typically delayed culture conversion at 2 to 3 months after treatment. The treatment of active tuberculosis includes an intensive phase of RIPE. So RIPE stands for Rifampin, Isoniazid, Pyrazinamide, as well as Ethambutol. By the end of the intensive phase, which typically takes about 2 months, the results of susceptibility will be back, and by then it will be known if the mycobacteria are susceptible to Rifampin and Isoniazid. Until then, it is important to have pyrazinamide and ethambutol to make sure that there is sufficient coverage of mycobacteria. Beyond the intensive phase, there is the continuation phase that typically takes about 4 to 7 months, depending on how the patient responds to treatment, and consists of combination of isoniazid and rifampin for drug-susceptible tuberculosis. We will not discuss multi-drug resistant tuberculosis in this topic. If the cultures are negative by the end of the intensive phase, a short duration of 4 additional months for continuation phase will be sufficient for a total of 6 months. So 4 months of continuation plus the 2 months of intensive phase. However, if at 2 months the cultures are positive and there is cavitation, that is an increased risk of relapse. So extended duration of therapy is needed. So 7 months plus the 2 months of intensive phase will result to a 9-month total duration of treatment. So the intensive phase consists of 4 drugs, RIPE. However, if the culture results come back for the susceptibilities prior to the end of 2 months, and it shows that the mycobacteria are susceptible to isoniazid and rifampin, ethambutol can be discontinued. So ethambutol is the most toxic. So it is important to discontinue ethambutol as soon as the susceptibility results suggest that it is safe. Because isoniazid is an important part of treatment for the entire duration of therapy, it can lead to neuropathy during this long duration of therapy. And it is important to give pyridoxine, which is basically vitamin B6, to patients who are getting isoniazid, especially for patients who are at increased risk of neuropathy. And those include patients who are pregnant, breastfeeding, persons infected with HIV, patients with diabetes, alcoholism, malnutrition, or chronic renal failure, as well as those who are of advanced age. Because the duration of treatment is very long, there are various regimens that have been studied, including regimens that are given daily, as well as more sporadically dosing, including 5 days a week, 3 times a week, and even 2 times weekly. And of course, the effectiveness of the regimen increases with increased frequency. So by far the best regimen that's recommended is the once daily regimen for the entire duration of treatment. And the reason the duration of treatment is so long is because mycobacteria population basically consists of actively replicating bacilli and non-replicating bacilli. So during the intensive phase, pretty much the actively replicating bacilli will be dropped. However, because the non-replicating bacilli will not be killed and it takes a long time for them to become active, it is important to continue for a long period of time in order to eradicate all these non-replicating bacilli. So as they become active, the antimycobacterial agents will eradicate them. And that is important to prevent relapse. Now, in January of 2025, new recommendation was added to the previous recommendations and guidelines by IDSA and CDC and others, essentially recommending a 4-month regimen of isoniazid, rifapentin, moxifloxacin, and pyrazinamide. And this is essentially similar to the previous RIPE regimens, except rifapentin has replaced rifampin and moxifloxacin has replaced ethambutol. And as much as fluoroquinolones are associated with collateral damage, they are much better tolerated than ethambutol, which is quite toxic. So this has the intensive phase, which is 2 months of rifapentin, isoniazid, pyrazinamide, moxifloxacin daily, and then essentially pyrazinamide is dropped and the other 3 drugs are continued for another 2 months. And it was a randomized control trial that compared two different regimens for 4 months. One is the one that's listed here that includes moxifloxacin, a second one that did not include moxifloxacin, and the third one, which is the control group, which is the standard of care RIPE therapy for at least 6 months. And here in this graph on the y-axis, we are looking at the absence of tuberculosis disease-free survival at 12 months. So essentially you want the numbers to be lower because that's the absence of survival. And you can see that in the control group, 14.6% achieved that outcome, and numerically higher percentages were seen in each of these groups. Now this was a non-inferiority study with a non-inferiority margin of 6.6%. So when you compare each of these arms to the control group, you can see that the moxifloxacin arm did achieve non-inferiority because it did not reach the NI margin, whereas the Rifapentine arm without moxifloxacin could not reach non-inferiority. So it failed non-inferiority, and that's where these recommendations are coming from. A regimen for 4 months that includes moxifloxacin is an acceptable treatment option. Of course, with the long duration of therapy, there is a concern for adherence. It is very challenging for the patient. So there is the concept of self-administered therapy versus directly observed therapy. And there has been a lot of studies done and comparing the two strategies. And the guidelines actually recommend that the directly observed therapy is preferred over self-administered therapy in order to improve adherence, which would reduce the risk of relapse. And DOT can be provided in the office, clinic, or in the field, for example, in the patient's home, place of employment, school, or any other site that is mutually agreeable. And this is very variable, so it, depending on where the patient gets treatment, this can be set up in order for the patient to receive their medication daily as DOT. After the 2 months of intensive phase, the continuation phase can be either 4 months or 7 months, and it is recommended to extend to the 7 months for patients who are at increased risk of relapse, including patients who have cavitation on the initial chest x-ray, and those who have positive culture at completion of 2 months of therapy. Additional factors to be considered in deciding to prolong treatment in patients with either cavitation or positive culture at 2 months, but not both, might include more than 10% below ideal body weight, active smoker, diabetes, HIV infection, or any other immunosuppressive condition, as well as extensive disease on chest x-ray. Here's a chart for monitoring that's recommended in the IDSA guideline. The shaded boxes are recommended only when necessary, whereas the other unshaded boxes are recommended. So there are recommendations at baseline and then at the first month, second month, and so forth. So it is recommended for when it comes to symptoms, it is recommended to monitor the patient's weight at baseline and monthly because weight loss is a symptom of TB. Other symptoms and adherence review at baseline and every month throughout the treatment. Vision assessment is very important when the patient is on Ethambutol. So typically the first 2 months when the patient is getting Ethambutol, and beyond that only if the patient needs to continue Ethambutol based on susceptibility results. For sputum smear and culture at baseline and monthly, and then beyond 2 months only if it's not negative by the end of intensive phase. Drug susceptibility testing is recommended at baseline, and then you don't really need it unless the patient's culture remains positive at the end of intensive phase, at which case it is recommended to repeat drug susceptibility testing at the next follow-up. Another reason weight is important to be monitored monthly is that all of the drugs are dose based on weight, so an accurate weight is needed every month and the dose must be adjusted based on that. For the liver function test, only at baseline unless there were abnormalities at baseline, symptoms consistent with hepatotoxicity develop, or for patients who chronically consume alcohol, take other potentially hepatotoxic medications, or have viral hepatitis or history of liver disease, HIV infection, or prior drug-induced liver injury. We described the PK/PD of antimycobacterial agents differentiated between latent TB and active pulmonary tuberculosis. We initiated a medication regimen in patients with latent TB, and we recommended guideline concordant first-line therapy for patients with pulmonary tuberculosis. Now, given a tuberculosis patient case, let's evaluate and manage drug-drug interactions. Majority of drug interactions are due to rifamycins. So in general, rifamycins are inducers of CYP enzymes. Now, rifaximin is not absorbed, so it's not used for TB, and because it's not absorbed, it doesn't really lead to any major drug interaction. But the other three rifamycins that are systemically absorbed and are used for tuberculosis can lead to drug interactions. Now, when we compare the three of them, Rifampin is a very strong, potent inducer of CYP enzymes, including CYP1A2, 2C9, 2C19, and 3A4. And this induction typically takes about 1 to 2 weeks to kick in. So it takes about 1 to 2 weeks for these CYP enzymes to be overproduced. And then upon discontinuation of rifamycins, it typically takes 2 weeks for this induction to wane away. So if a dose of a drug is increased to compensate for rifamycin effect, it is critical to reduce the dose within 2 weeks after rifamycin discontinuation. Rifampin is hepatically metabolized. It is not a substrate for CYP enzymes itself, and it doesn't need to be renally adjusted. It can also induce P-glycoprotein, so that's also one of the reasons for drug interactions. So in general, HIV protease inhibitors, non-nukes, and anything that's a boosted regimen interacts with rifampin because it's a strong inducer. Now, when we look at rifabutin, it is also a substrate of CYP3A. So rifabutin, you have to watch out if you use it with anything else that either inhibits or induces CYP3A. So rifabutin itself does auto-induction of CYP3A, and rifabutin is the only rifamycin that's actually renally clear, so it does need to be renally adjusted if creatine class is less than 30. Now, if we consider rifampin's potency of induction at 100%, rifabutin would be at 50%. So it's not as strong of an inducer, so it's considered a moderate inducer of CYP enzymes, so that could be one thing to use to manage some of these drug interactions. And rifapentin's induction is between rifabutin and rifampin. So rifampin is the strongest one, then rifapentin, and then rifabutin. Now, isoniazid is hepatically metabolized and it is not renally clear, so no adjustment. It is not an inducer, but it can inhibit 2C19. So this inhibition, which is actually moderate, can lead to some drug interactions, including isoniazid can increase the levels of phenytoin as well as carbamazepine, and it can prevent the activation of clopidogrel. So clopidogrel is a prodrug that needs 2C19 in order to be activated. Now, these interactions are if you are using isoniazid alone. If you are to use isoniazid in combination with rifamycin, these interactions actually flip to the other side. So when used in combination with rifampin, for example, which is a potent CYP inducer, the concentration of these medications are actually decreased instead of increased. Pyrazinamide needs to be renally adjusted with creatinine class less than 30. It doesn't induce or inhibit any enzyme, so it doesn't cause any significant drug-drug interactions. The same is true with Ethambutol. So it's renally adjusted with creatinine class less than 30. It's hepatically metabolized and no induction or inhibition of CYP enzymes, so no significant drug-drug interactions. So because rifamycins cause the majority of interactions, let's explore some of these interactions. So when it comes to HIV protease inhibitors, these protease inhibitors are strong inhibitors of CYP enzymes. So for these patients, rifabutin is preferred. And that's because rifabutin has the least amount of induction which can, you obviously need a booster for these agents, so you don't want to induce the CYP enzymes too much. Now, rifabutin itself is a substrate of CYP3A, so the dose of rifabutin needs to be decreased when used in combination with protease inhibitors. Efavirenz is an inducer, so for efavirenz, rifampin is actually preferred over rifabutin because rifabutin itself is a substrate of CYP3A. With rilpivirine, which is a substrate of CYP3A, cannot use rifampin or rifabutin. With raltegravir and dolutegravir, you can actually increase the dose of either raltegravir or dolutegravir with rifampin, or alternatively, you can use rifabutin and use the normal dose with these two, so that's manageable. Elvitegravir is boosted with cobicistat, so do not use with rifampin. Rifabutin can be used. Clarithromycin is a strong inhibitor of CYP3A4, so it may increase the rifabutin, which is a substrate of CYP3A4, to toxic level, so it's not recommended. And with doxycycline, it's shown that rifampin lowers doxycycline AUC by about 50%, and the mechanism is not really known, but it's best to avoid doxycycline. Azoles, with the exceptions of fluconazole, typically will have low levels if used with rifamycins. So fluconazole is not as strongly dependent on CYP3A4. Atovaquone has been shown to have subtherapeutic levels when used with rifamycins, so an alternative agent should be used for PCP. When it comes to oral contraceptives, because they are metabolized by CYP3A4, a second barrier method of contraception will be needed, for patients who are of reproductive age. For many of these, the interactions are manageable. So with levothyroxine, you can actually monitor TSH, and based on that, you may need to increase the dose of levothyroxine. With methadone, methadone basically is metabolized by many of the CYP enzymes. So an inducer a strong inducer can reduce the level of methadone, and methadone, is often used for opioid dependence. So these patients, might develop withdrawal symptoms. So if that happens, the methadone dose is typically increased. Alternatively, it's best to use rifabutin instead of rifampin if someone is on methadone. With warfarin, obviously you just monitor INR, and based on INR you can adjust the dose of warfarin. The same is true with cyclosporin and tacrolimus, which are drugs used for transplantation. We can get levels for these drugs, so therapeutic drug monitoring can help. The same with phenytoin and lamotrigine. We can get drugs and drug levels and do therapeutic drug monitoring. The same is true with digoxin. We described the PK/PD properties of antimycobacterial agents differentiated between latent and active pulmonary tuberculosis. We initiated medication regimen for latent tuberculosis and recommended guideline concordant first-line therapy for active pulmonary TB. We also evaluated and managed drug-drug interactions. Now, given a prescription for antimycobacterial agents, provide patient counseling for adverse effects. In general, rifamycins are well tolerated. They may cause some GI effects like nausea, vomiting, diarrhea, and abdominal pain, and they may lead to headache, fever, and pruritus and rash. Rifampin is the most potent drug against tuberculosis, so majority of patients will be on rifampin. It's important to note that rifampin must be taken on empty stomach, and although in general it's well tolerated, the adverse effects are more likely to be experienced by HIV patients. Some patients may experience flu-like syndromes like fever, chills, malaise, malaisias, and headache. And this happens several hours after dosing and usually resolves within several hours, so it's not long lasting. While rifampin can lead to some increases in LFTs, it's typically self-limiting and it's not really cause for concern. Now, serious liver injury is usually confined to patients with underlying liver disease due to alcohol, hepatitis, and other hepatotoxins like isoniazid. Very rarely, patients can develop AKI, which is typically due to acute interstitial nephritis with tubular necrosis, and it's not very common. Some patients may experience hemolysis and thrombocytopenia. This is why it's important to monitor platelets at baseline. And when someone develops petechial rash is when we really suspect thrombocytopenia, and we do follow up platelet monitoring to make sure the patient is not developing a severe thrombocytopenia. Some patients may have type 1 hypersensitivity reaction, like angioedema, bronchospasm, urticaria, and shock, which is extremely rare. And what is common with rifamycins is this discoloration of body fluids. So typically an orange-red color seen in urine, sweat, and tears, which can often cause soft contact lenses permanently stained. So that's an important education to provide to patients. Now with Rifabutin, it does not need to be taken with food, so it's either with or without food. One of the common causes of Rifabutin is uveitis, which is basically ocular pain and blurred vision. It can also lead to polyarthralgias as well as leukopenia and the same orange-red discoloration of body fluids as Rifampin. Rifapentine also needs to be taken with food, so that's one exception. So food actually increases absorption. It is dosed once weekly, so because it's dosed once weekly, compared to Rifampin and Rifabutin, it's better tolerated. So patients typically don't experience many of the adverse effects as other rifamycins. It can still lead to orange-red discoloration of body fluids. Now let's take a look at isoniazid, which needs to be taken on empty stomach. The same is true with pyrazinamide, needs to be taken on empty stomach. Ethambutol may be taken with or without food. However, considering that ethambutol is part of RIPE, so rifampin, isoniazid, and pyrazinamide need to be taken on empty stomach, and most patients will be taking this under directly observed therapy or DOT, most patients will end up taking ethambutol on an empty stomach anyway, but it's not necessarily required. Isoniazid is associated with hepatotoxicity as the major adverse effect, and that does include hepatitis, which is a black box warning. So patients who do develop hepatitis on isoniazid they need to discontinue it and be evaluated by an expert. Hepatotoxicity for most patients include increases in liver enzymes such as AST and ALT, and they resolve even with continued therapy, so it's not a major problem for many patients. Isoniazid can also result in neurotoxicity. Neurotoxicity includes CNS toxicity and peripheral neuropathy. About 17% of patients receiving at least 6 mg per kilo per day of isoniazid can be expected to develop peripheral neuropathy, and that is mostly because isoniazid does increase pyridoxine excretion. And in fact, one way to reduce the risk of peripheral neuropathy is to supplement patients with pyridoxine or vitamin B6 about 25 to 50 milligram daily to reduce the risk. And patients who are at increased risk of developing peripheral neuropathy include those with poor nutrition or underlying alcoholism, those with diabetes or uremia, HIV infection, or other risk factors. Now, CNS toxicity can also develop, and that includes memory loss, psychosis, or seizures. However, those are relatively rare. Pyrazinamide can cause nausea and vomiting, and it can also cause hepatotoxicity, but less severe than isoniazid. So hepatotoxicity due to isoniazid is significantly more severe than due to pyrazinamide. Polyarthralgia can develop, which is joint pain, and rarely there can be renal failure. Pyrazinamide can also increase uric acid, so hyperuricemia is associated with pyrazinamide, and in fact this drug is contraindicated in patients with acute gout. And ethambutol is also associated with peripheral neuropathy, but the major toxicity of ethambutol is visual toxicity. That includes optic neuritis, also impaired visual acuity and red-green color vision. And it's not clear if this is reversible. Obviously, if we catch this, the sooner we can catch this, the better the outcomes can be. So that's something that's important for monitoring for patients. Patients should report symptoms of blurry vision promptly and discontinue the drug until confirmatory visual testing can be done. Ethambutol is also associated with increased risk of hyperuricemia. Now, some of these drugs can be very severe, leading to permanent discontinuation of the drug. If a drug is discontinued permanently, it's important to replace it with a drug, typically from a different drug class, as part of the regimen. So management of serious adverse effects often requires expert consultation. Let's take a look at some of the adverse effects. So for GI upset, if the patient is doing self-administered therapy, they may take the medication at bedtime. Obviously, if they're doing DOT, they will have to go to the physician's office, so that would not be an option. And obviously, majority of RIPE regimens must be taken on an empty stomach. So because they are on an empty stomach, taking with food in order to reduce GI upset is not really an option. So what has been tried is that patients may actually take these drugs with an antacid, which may reduce the GI upset. And some experts actually report success with PPIs as well. But given the PPI epidemic, we don't really want to start patients on more PPIs than needed. And occasionally a light snack, with low-fat food such as 1 or 2 crackers, that can also help with GI upset without affecting the drug's absorption that much. With rash, it's important to, obviously all TB drugs can cause rash. It's important to catch the more serious rash. So when the patient is on rifamycin and petechial rash occurs, it may be suggestive of thrombocytopenia. If the patient has low platelet, it is important to permanently stop rifamycin and monitor platelets until improvement. For erythematous rash, also drugs must be stopped. And because all TB drugs can cause rash, when you basically discontinue all drugs, and when the rash has substantially improved, medications can be restarted individually at intervals of 2 to 3 days. So, you restart one drug at a time because you don't know which one of them caused the rash. So if the first drug was restarted and the rash didn't come back, 2 or 3 days later, you can add the second agent. And then 2 or 3 days after the third agent until the rash comes back. Then the last drug that you added caused the rash and you can discontinue it. Typically, when you stop everything and restart, you start with Rifampin first because Rifampin is the most potent drug. So you want to start the Rifampin first and then followed by Isoniazid and then Ethambutol or Pyrazinamide. Some of these rash reactions can be extremely severe. So, for example, Stevens-Johnson syndrome or toxic epidermic necrosis, and sometimes systemic corticosteroid may be used to treat severe systemic reactions from these drugs. For drug fever, which is basically a diagnosis of exclusion. So if someone has a fever, you obviously look for common causes of fever like an infection, cancer, VTE, etc. So if you cannot identify a reason, then you can, call this a drug fever. And so if the fever is due to the drug, you basically stop the drugs. And if the drug is stopped, typically the fever should resolve within 24 hours. And then you can restart once the patient is afebrile. And you restart drugs again individually. Every 2 to 3 days, you add one more. For hepatotoxicity, in the absence of symptoms, therapy should not be altered. So if there's a slight increase in AST and ALT, you can continue. And if the patient is symptomatic and ALT is more than 3 times the upper limit of normal, or asymptomatic but ALT more than 5 times upper limit of normal, it's recommended to stop drugs immediately. And then once the ALT goes down to less than 2 times the upper limit of normal, you can restart drugs. With hepatotoxicity, ethambutol is unlikely to cause hepatotoxicity, so you don't really have to stop it, but isoniazid, pyrazinamide, and rifampin will be the likely causes. Rifampin is the less likely, so once you stop the 3 of them, you restart by rifampin first, and then if no increase in ALT 1 week later, you can restart isoniazid. And then pyrazinamide can be started 1 week after isoniazid if ALT does not increase. If symptoms recur or ALT increases, then the last drug added should be stopped. And then lastly, for optic neuritis, the onset of optic neuritis is usually more than 1 month after treatment initiation. And this is typically due to ethambutol. So, it's important to hopefully by a month into intensive therapy, if the susceptibility results are back, it's best to stop ethambutol as soon as possible before this optic neuritis occurs. But, as we know, intensive therapy can go up to 2 months. And then once someone develops optic neuritis, ethambutol should be discontinued immediately. And if still no vision improvement, it's also recommended to stop isoniazid as well, because there have been rare reports of optic neuritis with isoniazid. This concludes this presentation.